Hello, everybody. Welcome to Dentist in the Know. This is the podcast where dentistry meets real talk, real news, and just the right amount of sarcasm. We're pulling back the curtain on the industry. We're talking to the experts, the innovators, and the everyday clinicians who are out there doing the work. No fluff, no filter, and definitely no sales pitch disguised as education. If it's happening in dentistry, from clinical breakthroughs to regulatory curveballs to the latest scandal at the ADA, we're probably already talking about it. And yes, we're bringing the receipts. So whether you're a seasoned doc, a curious consumer, a rep, a researcher, or just here for the drama, welcome to the show, because around here, we're not just in the loop, we're in the know. I'm Dr. Chad Duplantis, and it's an honor to be here with you tonight. I have one of my besties in the dental industry with me tonight, Dr. Jennifer Bell, and I'm going to go ahead and bring her to stage. How you doing tonight?
I'm good. How are you?
I
Here we
am
are.
doing great.
Humpday happy hour.
Humpday happy hour, bringing it to not just the dental community, but the people seeking the dental community. Yep.
Seeking. Yeah. They're all online tonight, I can tell.
That's right. That's damn right. Yes, you are correct. So what's been going on in your world?
Well, school started this week. And first off, like, wow, honestly, what a shit day. Like, just for the nation in general and stuff, like, it's just not a good.
Absolutely. I'd have to agree.
I don't know what to say about all that. And honestly, as a mom of a 10-year-old, between the floods, and we had a really bad boating accident here in our community recently, where a 10-year-old was also involved in that. And then this another 10-year-old. I have a 10-year-old, not trying to, personalize it, but I'm internalizing the fact that so much of it's a gift. And we all, as parents, we're all guilty of, I think, getting in the grind and, taking for granted just little stupid stuff. So anyway, mama heart is a little heavy, but in other news, before and after whatever happened today, school started on Monday. So we're back in the grind. Everybody's having to wake up early. It's not going well. The house is kind of a disaster from 5 a.m. until everyone's gone, and just, trying to get everyone back into a routine, which I never quit, by the way. Just everyone else did. They took the holiday. So,
well, as you know, for those of you out there that might be listening or watching, we're both parents, and we have jobs and we have families too. But my kids, I got one of them back in school. She started great, but here's the big win as a parent. As of yesterday, my college graduate is gainfully employed. So
with benefits?
I didn't say that.
Oh, okay. That's like top level.
Yeah,
it's gainfully employed, and then gainfully employed with benefits. That's like next level shit right there.
Gainfully employed with a paycheck is what he is.
Look, I love that too. I love that. Is it where he wants to be? Where is the job? Can he commute? Like, how's that work?
So, my son lives in Nashville, graduated from Belmont University, and he graduated with a film degree. Yes, you heard that correctly, a film degree.
Did you say underwater basket weaving? I couldn't hear you.
Basically the equivalent. No, I'm kidding. It's a very rigorous 4-year program.
It is.
No, and his ultimate dream was to be on like Saturday Night Live. So I think that is still his dream. However, he applied for several jobs. One of them was with a music producer in Nashville, which he was really excited about. And they were looking for somebody with no experience in the industry. But when it came down to it, they're like, hey, you fill the bill. We really like you. But although you have no experience within the industry, I think it'd be best if we went with somebody who was interested in the industry long term, whereas you're looking into videography. So they connected him with some other people that were like comedy
Nice.
scouts and stuff like that.
Yeah.
But anyhow, so he got this job like a few weeks ago, like a part-time job as a ghost tour guide in Nashville.
Right.
If anybody's ever met my son, it'll be perfect. Well, the ghost tour people, they have 240 locales that they do this ghost tour in. So this is like the largest ghost touring company, I'd imagine, in the United States.
It might be the only one.
Yeah, it might be. I mean,
Might
so
be.
like all these cities. So they realized that he was a creative writer and a videographer. And they said, hey, would you like a day job? And so he went in and interviewed. So he is rewriting all of the scripts. And of course, he will interject some comedy into them in all of their locales.
That's so awesome. That is
Yeah.
a real job.
It is a real job. So it's kind of what he wants to do. He loves to write. He loves to act. He loves to direct. And so we were talking tonight just before we got on the show. I was like, dude, if you want to talk to them about doing some videography kind of, around and see if there are some opportunities for you to film in these other locales. So there's opportunities. So
Is he
we're
looking for extras? I can be like a dead body walking kind of,
well, that might be more needed than because he's also producing another film. So
Oh, okay. Well, just let me know if he needs like a dead lady laying in a graveyard or something. I got him.
Well, you
I'm
need
here
to
for
talk to him because there might be a spot for that in his upcoming pilot that they're producing right now. So
That's awesome. Well,
yeah.
he knows how to reach me.
So hey, I'm just on cloud 9 because my kid's got a job. So anybody else got anything to say?
I have two big announcements for Dennis in the Know. Huge, big,
Okay.
huge.
Okay.
First off, next week we move to a new time.
That is big.
8:00. Because
7
Jeff has
Central.
to get to bed by 9. So we had to move it. We had to move it up a little bit so that he could be in bed at a more reasonable time. So for all our listeners out there, it's super important that you're locked in right now. I know. You bank on 8:30 every week. We're here for you. We're putting out the content. But because Jeff's sleepy schedule is not going to accommodate 8:30 anymore, we're going to have to move it to 8:00. And that's okay. Because honestly, you're going to come off of dinner, or maybe you're on the West Coast, you're coming off the high of a great day in the office, and you're just going to tune us right in on your way home from work, or as you're sitting down with your nightcap after a long day. We're here for you. And you don't have to wait for 8:30 either, because maybe your sleepy schedule is just like Jeff's and you don't want to be up until 9:30 listening to Jesse Yammer on. So starting next week, September 3rd, I believe it is, we will be changing our time to 8:00 Eastern time, going live every week, just like we always do. Hope you'll join us then. The second big announcement for Dennis in the Know, we have two big webinars coming up with some phenomenal educators. The first is tomorrow night. If you haven't registered yet, we've got the link in our bio, in Instagram, LinkedIn, and on our Facebook page. Ashley Clark, amazing. She is so amazing. She totally changed my perspective on pathology. If you haven't taken an updated oral pathology class in a while, you're really missing out. And if you're not capitalizing on feeling confident to do your own biopsies in your practice, Ashley's got you for that as well. We are a PACE approved and accredited organization, at least until September. And so we would love to have you join us, and you get Real CE and a Real CE certificate that you can turn in for your transcript. The second webinar is coming up on September 11th, and that is with another dear friend of ours, Tom Viola. Love that guy. He's such a dear friend of the pod, and he's going to give you CE credits for your opioid update. So really excited. We'll have all the links in our bios and stuff. So if you need more information, don't hesitate to reach out. But I'm just really excited about this journey with education, our new time change. Like, who are we? We're new people. It's like a new haircut.
Let's back up just a little bit. So first off, 8 Eastern, 7 Central,
Yeah.
5 Pacific.
Only people know it by Eastern because
Yeah.
that's where everyone lives.
Yeah. So 8 Eastern, 7 Central,
Yeah.
5 Pacific, 6 Mountain. However, I don't
It's GMT.
know that would be 6, right?
2 a.m., I think.
Oh, yeah, never mind. I don't know. I
Yeah.
don't know. I
Mhm.
don't know. Beyond that, I don't know how many people are aware of this, but kudos to you, JB, because these people that we have on these webinars are really just second to none. And I mean,
Absolutely.
hey, here's the deal. I know that the tonight is for the general public, but if you're watching and you actually want to learn something about oral pathology or what us dentists go through, we're not going to discriminate. If you want to get some
Yeah,
credit
I mean,
hours,
if you really wanna
we're happy.
understand.
Yeah. But the pharmacology is a big one too, because we might be able to see why dentists don't prescribe opioids as much as they used to. And
Right.
some of the changes that we go through. But Tom and Ashley, I spent the weekend with Ashley last weekend. She's just such a phenomenal human being and educator. I mean, 2 full rooms all day Saturday, just a great person and a very knowledgeable educator. So
And she's
really excited.
fun. Like, pathology is it's not the sexiest topic. I'd put it up there with dental materials for me. I'd put it up there with, uh, maybe periodontal disease, also not like a super sexy topic, but she's fun. So she takes and turns it into a wow.
So we were talking last week, and I was telling her that during my residency, every Monday from 1 to 3, we would have pathology, and it was with Dr. John Wright, and he's an amazing pathologist. But to be quite honest with you, Dr. Wright, I'm sorry, I know you're not listening, but if you were, I'm going to apologize because it was kind of boring at times. But I love pathology, and so everybody used to laugh because here it is right after lunch, and I would fall asleep as soon as we sat in the room because there's 12 of us in a room and it's pitch black. And I'd sit up against the wall and I'd fall asleep. However, I was still answering the questions in my sleep. So throughout residency, they called me the sleeping pathologist because I would answer questions with my eyes
You
closed.
should start signing your lab
Uh,
scripts to
yeah,
Ashley when she reads it. Love the sleeping pathologist.
yeah, and we had a good laugh about that this past weekend, and but one of the things I will say is that she's taught at so many places, and all of her students just
Yeah,
truly love her. She's really a good person. Do you have a news segment for
of
tonight?
course.
All right. Well, would you like to get to
I
it?
would love to get it out there.
All right. Well, I will leave you be with that.
Thank you. All right, team. There's a couple interesting developments that has happened over the last month or so. One that actually wasn't on my radar. I'm a little disappointed in myself. But I want to be the one to bring it to you tonight in case you also feel like you missed out. Are you aware that Delta Dental purchased some practices in Wisconsin? Yep, that's right. This is a new age and a new dawn of dentistry now that we have dental insurers starting to purchase practices. So in July, early July, Delta Dental purchased Cherry Tree Dental out of Wisconsin. Yes, I said the state correct. Now it raises some pretty serious concerns about conflict of interest, perhaps. Maybe that practice will only accept Delta Dental. Maybe they'll be able to do price controlling. And what will that look like depending on the number of locations and its distribution throughout the state? What will that look like for the other dental providers who also participate as an end network provider for Delta Dental in the state of Wisconsin? And where's their next target? What state will allow an insurance company to come in and purchase additional practices? I don't know about you, but this concept has not been fully vetted, and it leaves me pretty icky in the tummy on where this will go with dentistry. So I don't have any updates, but I think this certainly is going to have to be under review. I think it could be potentially some legal ramifications and some regulatory implications that will come from this. I guess we'll get the luxury of the hindsight review. Remember, Wisconsin's really been pushing the envelope lately on what they've been allowing to happen in their state. They were, in fact, the ones to allow their new dental graduates to bypass a hands on in person clinical exam for licensure. They are opening up the compact and allowing interstate commerce of dentists and dental providers to come across state. And they also are a pretty big advocate for mid-level provider. So, as dental patients of Wisconsin, read the fine print. Another story coming out of Florida, we haven't seen a lot of activity in the amalgam space in a bit, but the general surgeon or surgeon general, gosh, surgeon general is late. Florida just came out advocating against the use of amalgam for restoration. Now, we've seen this uptick a little bit in New England and a little bit on the upper northwest coast of the US. A lot of campaigns against the use of amalgam. It'll kind of simmer up and then it comes back down again. But now we're seeing more and more states starting to verbalize how they feel about amalgam, not just from the regulatory piece of the EPA and how the amalgam is entering the water supply and how we protect and minimize that impact. But now we're seeing for the first time actually in a bit, a state kind of coming online saying that they're going to be advocating for no more amalgam restoration. So I'm sure that will open up a floodgate of discussion. I'm sure it will open up a floodgate of lobbying and discussion about whether or not so goes Florida, so goes the rest of the union. Who knows? But another restorative material is up for debate. And we know fluoride has been a hot topic for a while. That hasn't stopped. I think obviously the nomination of RFK and confirm is continuing to sort of simmer that pot just a bit. And so there's been a couple of things that have happened over the last few weeks. One of them was a coalition that put together an advocacy group to go against the fluoride management, I guess. So they put together an act called the Teeth Act, largely Democrat supported act that is intended to require the EPA to go through another organization for independent, non-biased review when it comes to the regulation of fluoride in the water supply. Obviously, dental organizations are supporting that because of the push to eliminate fluoride in municipal water supplies and to get an independent review from a scientific group to make sure that that is in the best practice. So again, fluoride is a hot topic, top of bill for discussion. And with that, that's the news.
I heard everything that you said. However, is there really a surgeon general in Florida?
Damn it, it's no. Not a surgeon general, a general surgeon. There's only one though. Only
I,
one.
I was just curious, I
Yeah,
was
only
curious.
one general surgeon.
I was just curious. I had I think this is a great segue because, you talked about a couple of things that really could hit with the consumer, but I remember years ago, this is going back to when I graduated from dental school in 1999. So let's talk about alloy or amalgam for a second.
Yeah.
I went and visited my roommate in college. His dad was a dentist, and I was in the midst of shadowing offices and trying to figure out where I wanted to practice. So I went to his practice in a really upscale community in Houston, and this guy wasn't like, I mean, he was a really, really good dentist, but he wasn't like just crazy, like cosmetic high end, just like, you know, what you would consider the best of the best. He was what I would consider a high end bread and butter dentist. And that's kind of what I always wanted to be too. Just you do a little bit of everything. But you really focus on making people happy. So we were talking about filling materials and I was like, well, do you do any amalgams? And he goes, no, I don't. And I said, why? He goes, well, let's back up for just a second. And he says, let's say that we went and pitched this perfect product to the ADA or the FDA. And I'm like, okay. I mean, here I am in school. And he goes, let's just say that we say, they say, well, what is this product? And he's like, oh, well, it's a product that adapts to the tooth. And it's kind of an amalgam of a lot of different metals. There's a little tin, there's a little aluminum, there's, and it's a powder and you condense it in there. And they're like, well, that's great, but it's a powder. So what holds it all together? Well, just a little bit of elemental mercury. He goes, do you think that that would ever pass with the FDA and the ADA of today? And I go, probably not. And he goes, but it's been used in dentistry for years with great success, right? And I said, yeah. And he goes, I'm going to model my practice on what would be passed through the FDA today. And he goes, and I don't think that it ever would. And that always has stood out with me because, like, honestly, if somebody pinned me and said, what's the composition of amalgam? I'd have to dig really, really deep and think. But the one thing that we all remember is
Is
mercury.
mercury.
And that's it. And granted, the thing is we all know the dangers of mercury. But I don't think that we really think about that because I couldn't tell you everything else that's in it. Could you?
Mm-mm.
I mean,
10,
what's that?
10, nickel.
Yeah, I mean, I was like throwing two metals out just a second ago, going, I think that's part of it, but I'm not sure. But I know for damn sure it had mercury in it.
Yeah.
Now, the real question, and I don't know that there's enough literature to support this, but the real question is that okay, if somebody's had it for years, how detrimental could it be to their health? And how detrimental is it to remove it? And, you know, I don't know that there's enough literature to support either of those, but I do know that on our offices, we're required to have amalgam separators so that it doesn't go back into the water supply. I know that's an expenditure. So, we're kind of going around everything that says it's unsafe without saying that it's unsafe. We're like tiptoeing because it's been in existence for years. When was the last time you did one, JB?
It's been more than 10 years. I did do them in private practice because right when I came out, again, that crux of analog and digital, and people, most insurance companies were still paying an amalgam-based rate for composites. You don't really see the downgrade too often anymore, but for sure that was happening. So if you gave them like, $250 for a composite or $180 for an amalgam, they would pick the amalgam. And so I did that for a bit, but the demand was so small for them. I didn't want to routinely place them, but the demand was so small that, you have to buy them in these quantities, even 50 compules or whatever. And I might use two and then it would expire and I'd have to throw it out and order another. And I'm like, what am I doing? Like, at some point you're just like, we just don't offer it. It's not a good service to the patient. And I often joke with patients, maybe a little flippantly, but when they ask about the health of, removing these and stuff, and I'm sure that there's a short-term inflammatory consequence of that. I mean, it is with everything we do in dentistry, so I'm not naive to that. But I actually would really like to know what the long-term consequence is to dentists because on average, we remove however many a day and we aerosolize that right back into our face. And we know, unless you're wearing like a respirator or something, those stinky little masks are like keeping your stinky breath from the patient's stinky breath and kind of vice versa, but they're totally porous. And so, I think it is important also from a health and safety perspective, like what is the adverse risk to the dentist that's now ripping all of these things out and it's coming back. So I will say when patients ask, like, is this unsafe for me? Is it dangerous? And I say, I promise you it is way worse for me than it is for you
Yeah.
because you're now my 10th of the day. So I'm sucking up amalgam all day long and just, putting it into my system and enjoying your biofilm and all your bacteria and your mercury simultaneously, just sucking it all into my space. So I think dentists should be judicious with isolation, rubber dams, isolates, isodries, whatever, whatever dry shields you think. I think that's helpful to eliminate or alleviate some of the swallowing of the metal material. And fast forward another, I don't know, 15, 20 years, we're not really going to be doing amalgam, even removal at that point.
Well, we bring this up, and I think it just so happens that it was your news story, so that's kind of where we start off. But we have, I want to just reiterate, we're not knocking anybody or downplaying anybody that's had a sensitivity to amalgam or had medical issues that have seemingly been resolved since the amalgam's been removed. I mean, everybody's an individual person, but it was used for years, and we do know the dangers of mercury, and it's something that, we've decided not to place. I've done two since 1999.
Yeah.
And that's really the extent of it. I think the last one I did was probably in 2005, 2006, and it was at request. But you also brought up another good point, because this came up in my office this week. So since we're talking about patients, and I know we've already had an episode on why won't my insurance pay for this, or what is dental insurance, we had two that were downplayed to an amalgam now this past week. So meaning that the patient came in, they got a tooth colored filling, and the insurance company paid on it as if it were an amalgam. Now, I want to make it very clear, and I think Jennifer will agree with me on this, is that your insurance is not telling you that the amalgam is the better restoration.
Mm-mm.
The insurance is not telling you that you can't have a tooth colored restoration. Basically, in this scheme to make money, they know that the amalgam is the lesser of the two. They know that it would serve a purpose. So they're going to say, you know what, we will only pay for an amalgam restoration, not a composite restoration.
It's
Beyond
akin
that,
to saying we'll only pay for a gold front tooth. We won't pay
yeah,
for a porcelain front tooth, because if you want porcelain, clearly you're just in it for the cosmetics.
exactly. You're in
And
it
you're
for
like,
the
"Wait."
cosmetics, and it takes more skill, more effort, more bonding, more this, more that.
And
You know,
honestly, would you not? I mean, this is very much my own opinion. I actually would charge more for an amalgam at this point than I would a composite. Number one, because I have so much material waste because I'm not using it enough. Number two, it is incredibly technique sensitive. And if you're not doing it on a regular basis, to me, it's actually more difficult than doing a composite at this point. So
yeah,
I
yeah,
don't know. The
it is.
downgrade is such an antiquated thought process for insurance companies. Honestly, like that's incredibly antiquated.
Well, I always say, and I don't care if insurance companies are listening. I
No,
always
I
say
don't care.
this. Insurance companies, there's a person or a bot behind the screen that's checking boxes. Did they do an amalgam? No. So we're going to check the no box. So that means that they did a composite. So it's going to be paid for as an amalgam. So we're going
Because
to
it's
pay.
just an aesthetic restoration.
Yeah. And then on a crown, did they send a post-op x-ray? Nope. Okay, we're not going to pay for that. We're going to send a letter back out to them and ask them to pay for it. Oh, this one's a big one. It's an implant. Did they send in an FMX? Nope. Are dentists still taking FMXs?
Are they? I'm sure some are.
Well, insurance companies seem to require it, for implant restorations. So, I came up with this with this letter that works kind of well, where when they send a request for an FMX or for a radiograph that we don't have, although we have all of the necessary radiographs to make appropriate diagnoses or whatever,
Correct.
I send them the 2012 ADA guidelines along with a letter telling them that I appreciate their concern. However, I refuse to over irradiate our patients because, according to the ADA and the FDA, radiographs should only be taken when used for diagnosis and or treatment. And this radiograph request from you all is neither of those. So
Correct.
here's your letter, here's the guidelines, and here's what we have. Take it or leave it. And it seems to work. So
How can you argue it?
you can't. You
We
can't.
just had a request from this is going to end up being an insurance bashing session, but fine. We just had a request for re-cements of a crown. So if a patient comes in and a crown pops off and everything looks good, you can just pop it back on, no big deal. Sometimes I'll take a bite wing. I mean, if the patient has been asymptomatic prior to coming in, the crown came off, tooth looks healthy underneath. I'm going to take a bite wing to make sure I've got it reseated appropriately, because if it's been off for a little bit, you just want to make sure you've got it reseated and sealed. I don't always take a PA for that because I'm not looking for infection because the patient's not coming in with infection. Now the insurance company is asking for a before and after cementation PA for for an $80 procedure for a re-cementation of a crown.
So the moral of the story is that, and I love telling patients this, and I'll tell you right now, insurance companies, believe it or not, they're not necessarily here to pay for everything that you have done at the dental office or even the medical doctor. I think their main goal is to not pay for that. You know, there's they want to keep as much money as they can because they're in turn of a profit as well. But the requests are getting ridiculous as to what they ask for. I saw a dentist the other day that cemented a crown, and there's a phenomena that the crown, when it goes on the tooth, is very white or very opaque. The tooth is a lot less white and a lot less opaque. It's still somewhat opacious, but there's a huge variance in the crown's appearance on the radiograph versus the tooth's appearance on the radiograph. So there's a phenomenon that occurs with a very popular crown material that it looks like there could be a little decay at where it meets the tooth, and it's actually a proven phenomena. I'm going to call it burnout, but I know that there's a specific name for it. And insurance companies have denied paying for crowns because they have recurrent decay on a crown that was just cemented because it has that little radiolucent line right where the crown meets the tooth. I mean, come on, folks. So there you go.
Okay, so amalgam. Oh, I did want to make one analogy with amalgam. I
Yes.
know this is probably going to put me in hot water. I'm probably going to get a letter. Okay.
Yeah.
But we don't paint with lead anymore.
No.
We don't put asbestos in houses anymore. I'm actually not arguing that the materials that we use are vastly superior, because I think it's just a matter of time before we start seeing the lawyer commercials of, "Did a dentist put a composite restoration in your mouth? You might be entitled to compensation." Like, I totally get that it takes time for these things to manifest. So I'm not arguing that everything today is vastly superior to amalgam, but we do know the toxicity of mercury. We do know the toxicity of asbestos. We do know the toxicity of lead paint. And we've stopped using those materials for that reason. Now, science will catch up with all the new ones and we'll figure out where we go from there. I get it. But saying we should do amalgams, number one, the number one advocate or the number one argument for having amalgam restorations that you will hear is that it is a less expensive material and available to the poor, which means that you're advocating for tiered care. What you're advocating for is that people who can't afford dentistry don't deserve good dentistry, don't deserve newer materials and newer technologies. I fundamentally disagree with that. And you can do new stuff at the same economics of doing an old amalgam restoration. So I think that's an old, additionally antiquated argument. And so you'll hear, well, what happens when you take that away? These public health clinics won't be able to serve their population anymore. Would love to know currently the number of amalgam restorations also coming out of public health clinics, because I would argue it's probably pretty low, because you actually have to have special techniques and technology and all these things to even do an amalgam anymore, which a lot of offices don't even. I don't have a triturator. Haven't had a triturator in 10 years. I can't actually do an amalgam. I don't have the equipment anymore to do an amalgam, but I have a little gun and I can do a composite, and that's very low tech investment there for me. So just advocating for an open-mindedness when it comes to like the evolution of materials. And again, I'm not saying composite is vastly better. It is plastic. And I think all the stuff is coming out about plastics and BPAs and formaldehyde leach. And there's all kinds of other things that are happening in a negative space for composites. And I can also argue they don't appear to last as I have never seen a 40-year-old composite ever. Not one. They probably have only been placed for 30, but I've never even seen a 30-year-old composite.
They've been around for 40 years. If you see some that are really grainy, you know, they're
Or
there.
or radiolucent. Like
Yeah.
and those do seem to last, but you know.
So, hey, where did the phrase "mad as a hatter" come from?
I don't know. Like Alice
You
in
really don't know
Wonderland?
that? Well,
Alice in
Alice in
Wonderland?
Wonderland, but do you know what made the hatter mad?
No.
Mercury poisoning.
Oh, right.
No,
See?
look it up. That's where Mad as a Hatter came from. And I also encourage everybody to and granted, I mean, I don't know the extent that mercury was used in the hatting industry back in the day. However, there is a great podcast. Have you ever seen? It's called S Town. It stands for I believe it was Shit Town, but it's S dot 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 town. I encourage everybody to listen to it. It's a fantastic podcast. It's about this small town in Alabama, and there were two industries back in the day where mercury was very prevalent, and it was hatting as well as clockmaking. And I won't lead into it, but
Don't ruin it for everybody.
all comes to fruition through the podcast S Town. It's really, really good. I listened to it a number of years ago, but I would highly encourage you all to listen to it. It's kind of fascinating, and just you'll kind of see where I'm going with it as time goes on. So, hey, let's take it back to basics.
Okay.
Let's switch gears.
On it.
So I had no idea that we would pivot into this, but it's just kind of like what we usually do. You know, we always find something to talk about and
Yeah.
it comes organically. So I'm really glad we got to talk about amalgam. But we had some great.
Guess what?
My
Hold on. We can't do
goodness.
this alone.
There he is. Hey, hey, hey.
Our third bestie came in. Yes.
Yeah.
I couldn't help it. I finished my webinar and I said, you know, there's only two things I can do after finishing a webinar. And I'm sorry I interrupted you, Chad.
No, you're fine.
There's only two things I can do. One is grab a glass of wine and be with my besties and nerd out some more.
How do you feel about mercury?
Is that what we're talking about?
We did a little bit.
Yeah.
Yeah, it's my favorite planet.
Yeah.
And that's the answer.
And that's the answer.
How close is it to Uranus?
I think we all know.
Yeah. So is this what happens? I come on and it just goes downhill immediately.
Yeah. Immediately.
No, you just missed a great conversation. We had some great news segments, and you know, we just kind of like I was just saying, we kind of do what we usually do. We kind of get it goes organically, and we find things to talk about. We had a great conversation on mercury. I'm going to ask you, Jeff, because you weren't here. Jeff, where does the phrase "mad as a hatter" come from?
I didn't know either.
Alice in Wonderland?
That's what I said.
Well, you are correct, but hatters are mad because of mercury poisoning.
Really?
Yeah. So
there's apparently a lot of mercury in hats.
What? They used mercury in the fabrication of
top hats?
I don't know if it was the fabrication. No, it says it was used during the felt making process.
Felt
making process. Yeah. So, but we were just talking that there are two industries that I know of where mercury is very prevalent, and that is hat making back in the day. And I don't know anything about the hats these days, but the other is clock making, or watch making. So mercury is very prevalent in that as well. So they had a tendency for hatters and clockmakers to go mad because of the mercury poisoning. So there you go. Learn something new every day.
That's really interesting. I would have never known that. I wouldn't have. You could have had me guess for the next 2 days, and it wouldn't have happened.
Never came to mercury.
Yeah, and the funny thing is I was trying to bring that, and I wanted to make sure I fact checked myself. So I was like, hey, what was I Googled? I said, why did the hatter go mad? Just to make sure. And sure enough, it was mercury poisoning from the felt making process.
So what was did you guys have a debate on mercury, or what ended up happening here? I mean, what was the discussion? So I have it in context.
Well, no, we were just talking about how in your practice, that's all that you use. So we were talking about how you were
still squeeze through the cheesecloth. Yeah.
Yeah,
No,
all
we were just-
interior crowns are made from silver.
we actually had a good conversation about the longevity of amalgam, but the fear of mercury, and kind of how it's looked upon and frowned upon and not really widely used in dentistry anymore. And not knocking anybody that's got symptoms that could be due to mercury poisoning, but or not knocking anybody that hangs their hat on removal and in a safe and effective environment, but just that it's not being widely used anymore, and
Yeah.
why we don't.
My opinion on, as long as everybody understands, because there's this craze as if, everyone's silver fillings are leaching out all this mercury, and we don't have the data that that's happening. I mean, the mercury is bound in amalgam. I mean, the only time that we're really seeing the mercury vapors is from removal.
Yeah.
What you
We're the
pointing
only
at.
ones going crazy. That might be explaining some of
Right.
the mental
It's
health
really
crisis.
right. We're the ones who are the most susceptible, just being exposed to that day in and day out. With that said, if someone had a neurological condition and they just wanted to rule everything out and they decided to go that path, I just don't know that we have enough evidence that it'll be of any real help, based on what we know, because all that bound mercury is not toxic in the form that it is in silver amalgam.
I would agree.
And that's all I got to say about that.
Love it.
Well, we hadn't even gotten to some of our questions.
Let's go. Rapid fire.
In our informal polling. Some of these are funny and some of them are very serious.
Let's
but we
do a
did
funny one.
Okay. Well, I mean, they may not be funny to the general public, but they were kind of funny to me. Okay.
Okay.
So here's one that came in. This is from Susie in Ontario. And Susie wants to know, she says, my dentist always talks about brushing, rinsing, and flossing. However, they have never given me an exact order in which I am to do so.
That's a great
Inquiring
question.
minds want to know. And it's so funny that this came through because I have a very specific method in which I tell people to do so. So let's do rapid fire. Go around. Brushing, flossing, and rinsing. What do you do, JB?
Okay. What do I do and what do I recommend? Might
What do
be
you
two
recommend?
totally different things, but
What do you recommend to your patients?
Do as
My
I
gut.
say, not as I do.
Somebody
my
says what
gut,
order?
my intuition says floss first, brush, and then you rinse.
I'm with you. That's
If you rinse, I'm actually not a huge advocate of rinses. We can talk about that another time, but if you're going to rinse, I think you do it at it's a scorched earth mentality at that point. You're just trying to radiate and nucleate anything that's still left.
Okay.
I love the rinse thing. Because a lot of
Well,
times
I like certain rinses, but
right,
globally
but
speaking,
it's
I'm very
less
specific.
about what they're rinsing with than it is the actual function of having pressure in between the teeth and moving stuff around and getting it out of there. So it's really more, I'd rather somebody rinse with water,
Sure.
and in fact, we tell a lot of our Invisalign patients, take your trays out. If you're not in a place where you can brush, just do a good rinse with some water before you put your trays back in. I just think rinsing is a great last technique, and it's more important to do so than it is, about with what you are rinsing.
Right.
Now, if you have like periodontal concerns, I would say that something that's antimicrobial would be great. But if we're just talking the average patient who's otherwise healthy, I think it's awesome. And I don't think you have to be so worried about what you're rinsing with. And rinsing with the wrong thing could actually be bad for you.
Agreed.
So
Don't rinse with Mountain Dew.
I'm going to throw a wrench in the equations because I have a very specific methodology, and I'm going to tell you why. So I say we go in alphabetical order. I say we brush, we floss, and then we rinse. And the reason that you do so is because you're brushing with a fluoridated dentifrice. If there's any incipient lesions, when you floss, you're going to bring any of the residual toothpaste
Okay.
down in
All
between.
I like
That's
it.
your logic.
between
like
That's
it.
your logic.
And then we're going to come back with a rinse, and the rinse is going to be hopefully fluoridated too. And I'm going to throw this name out there because Listerine should partner with the show. But I like Listerine Total Care. I like Colgate Peroxyl. There's Colgate Peroxyl's not every time, but I do like that occasionally. I like something that's really going to provide a little bit of fluoride and kind of, like Jeff just said, that pressure in between the teeth. So I just said, let's do it in alphabetical order, and they'll never forget it. Brush, floss, and then rinse. But leave a little bit of the toothpaste in there so you can bring that toothpaste in between the teeth and get those incipient lesions.
Yeah, I actually I see the logic there, and I would add to that and say, ask your dentist what you're most at risk for. So,
That's
if
a
it's
great point.
if it's a caries risk, or if it's a periodontal risk or a gum risk, you might choose two completely different rinses. Looking for something that attacks the bacteria that work under the gum versus the bacteria that work above the gum. So
Yep.
I would say ask your dentist what you're most at risk for, and that would help you determine what it is that you use to rinse with. But I
So,
like it.
Susie from Ontario, the science is just not settled.
Yeah.
Here's
I would
what I
agree.
will say at the end of the day. Dentists would just be happy if you were doing all three.
Exactly.
They can just lock around you on that.
Yeah.
Exactly. All right.
Next
And
one.
honestly, Susie, I don't know if you're from Ontario, California, or you're from Ontario, Canada.
Oh, yeah.
But I
Was there
can
an
tell
A
you
at
that
the
one
end?
of my really good friends, who's a dentist, his wife and he were booking trips to Ontario, Canada, and his wife booked one to Ontario, California. And
Oh,
Mm.
that is so the wrong direction.
That's a big difference.
And I
Yeah.
would go ahead and tell y'all that that was Dr. Ryan Walsh, and they did end up in the same place.
Oh,
And
Lindsay.
yeah. So they ended up in the same place, but it was a really funny story. So,
Yeah.
okay, I'm gonna pick another one since we're short on time here. There was a
I like rapid fire. Let's go.
Yeah. Let's do it.
Okay. This is a big one. Braces or aligners?
Huh. Who's
And
first?
this question is actually from your namesake, Jeff. However, from Northern Florida.
Okay. Well, the Horowitz were either in the Northeast or Florida. It's
No, actually, just Jeff. I don't know the last
It's
name.
just Jeff. His name's Jeff Smith,
Yeah.
and
Yeah, just Jeff.
he's not
Horowitz.
related to you at all.
Yeah.
This is from a Jeff H. in Myrtle
Yeah.
Beach, South Carolina.
He's curious about his future.
Yeah.
Again, it depends on what your risk factors are. You have a patient that's a higher caries risk, higher risk for cavities. Somebody who maybe has a tougher time with their home hygiene care, say if they have issues with dexterity, where I don't think they'll be able to clean around the brackets as well, then my preference is absolutely going to be aligners, because we know that the home care is typically easier with aligner therapy. Depending on what type of a skeletal relationship it is and what you're trying to accomplish, I might be more apt to use what we call straight wire or traditional braces for specific tooth movements. It's really, everything for me is case dependent and risk dependent. And, but I am learning that I am doing so much more with aligners than I ever believed I could do 10 years ago, even.
I knew we'd go down a rabbit hole on this one, and this could really take up an entire conversation. But I think what it boils down to in my practice is the compliance from the patient as well as the complication of the movements. And I always, if I refer, I mean, if they're seen in my practice, they're going to be seen with aligners, but I'm not going to do aligners on everybody. If I feel that they need something else or something more complex, they're going to go to, an orthodontic office for sure. But like you said, Jeff, aligners are evolving daily as to how advanced they are versus how advanced they were when they first came out. There aren't a lot of things that can't be done with aligners nowadays as opposed to the past. And so it's a harder judgment call from our perspective, but I think it becomes more of a compliance issue than it was in the past, where we really just got to focus on compliance as to what's going to be better for the patient. But I always tell the patient, I defer to the orthodontist if I refer them. That's a question for the orthodontist, and it's going to be what they feel is best for your given conditions. But I love aligners.
I would also add that I think aligners are great for perio patients if you're trying to treat occlusal issues or bite issues that are associated with worsening periodontal conditions. I love aligners because of the stability over the teeth. Your control of forces is so much better with aligners than it is with wire, I think. Jeff, you might be able to comment better, but it seems like it's a more steady, methodical amount of force that's being applied over a period of time, as opposed to, maybe over torquing or over engaging a wire as you go. So I love it for perio patients if we're trying to solve some issues, but we're trying to be very gingerly with our care and like trying to move teeth without over exaggerating the periodontal support. Like, I love that. I think we're pretty close. Pretty close. In the right hands, with an orthodontist or whatever, there's probably not a ton of limitations on aligners anymore over straight wire. You may need additional anchorage to do some of the stuff you're trying to do, but man, it's come a tremendously long way. The other piece that you cannot ignore is the ability for patients to participate in their care to keep going. Like that whole gate of the traditional orthodontic model, where I can only go as fast as I can get appointments into my orthodontist office to get the next wire engaged or tweaked or new elastics put in, or whatever is the next step. The ability for patients to have some ownership of that continuation of care, so I can give them what they need and they can go home with their instructions and they can keep moving week after week or every 2 weeks or whatever, as opposed to me being some professional gatekeeper to say, well, I can only engage you every 8 weeks because that's what my schedule will allow. And so it's going to take you 3 years to finish your care because that's how frequently you can get into the office. So I think you cannot underestimate that value. And particularly for today's consumer, there's a lot of intrinsic value that comes with that, to be able to participate in your care. But I agree with both of you 100%. Compliance is the biggest issue. But I think actually orthodontists would argue the same thing. Like they'll set these cases up, right? And it's based on elastics wear, it's based on all these things. And when the patient doesn't do that stuff, the plan falls apart. So aligners might be somewhat more unique to that because you can actively totally disengage with care, but compliance is really an issue. So for all those parents out there, because I think it predominantly sort of pertains to that audience, if your child is not ready or wanting to participate and they're not motivated, they don't care that their smile looks the way they are, as much as you want to take advantage of skeletal growth and some of the other things, if they're not in it, man, it's such a hard road. And at the end of the day, I think all three of us would agree the care is compromised. We just don't get what we're hoping for. We get some of it, but not all of it. It's improved, but not great. And it really comes down to compliance with orthodontics. Like the patient has to want that process. Don't you think?
I totally agree.
100%. And that absolutely translates into straight wire. As someone who has been doing traditional braces and engage with aligner therapy. I mean, I've treated adults, I've treated children. First point that you made was absolutely the application of forces are definitely spread across more time, which makes it more comfortable and addresses the periodontal issues that you talked about, JB. Adults by far are way more comfortable in aligner therapy. Anecdotally, I mean, what I've seen across the board, I've never had an adult patient go through braces that didn't complain about discomfort. And it almost never happens with aligner therapy for adults.
Yeah.
So it's really two different worlds on that front. With that said, I still have cases where I've told adults there's no way this is going to happen without traditional braces. But I think that the point is has to be made or I should say reinforced that you made, which is it doesn't matter which modality you use. If the patient isn't involved, even regular braces is not going to work out well. It will not end well if the patient isn't engaged in their own treatment. And so that's not unique to aligner therapy.
You know sorry, I got to tell this one quick story. You know the brackets with the pop? What are those?
Oh
The
yeah,
The Damon brackets.
Yeah,
the Damon, and you can open the window.
Self-ligating or
Yeah. I had an orthodontist friend call me, and he was like, "Man, this patient, like, they're just not moving." But the kid had figured out how to pop them all open and pull his wire out, and then push them all back down. And so he saw him for like months, and he's like, "Man, these teeth are not responding to treatment. Nothing is moving." So finally it dawned on me, he's like, "I kind of wonder, like, is he really even wearing, like, are we even moving teeth?" So he asked the mom, he said, "Can you please just look for the straight line all the way across and not pay attention to the actual brackets?" And sure enough, literally, as soon as he got out of the ortho office, he'd figured out how to pop them all out, pull out the wires. He'd go the whole month without wearing it, put it back in, lock it back down, show up for his wire check. Because it was too sore.
That is pretty genius. And I just think one of the morals of this story is that whether it's your general dentist or an orthodontist that's treating you orthodontically, make sure that you feel the confidence of that practitioner. And if they refer you, if you're referred to an orthodontist, you don't want to go to a one size fits all shop. You want to go to somebody that does things in different ways and chooses what's best for you in any given situation.
Absolutely.
That's what I'd say to that. We've run out of time, but I just got to throw out this last question real quick. Okay.
30-second rapid fire.
30 seconds. Okay. Yeah. I need that. I need a time limit. You got to put a time.
30
I'm
seconds.
still going to screw it up, but.
Hey, well, this is a tease because I don't even know if we need 30 seconds. Now, I'm not going to throw this person's name out there, but it says, "How long will my dental procedure last, and are there any ill side effects?"
What's the dental procedure?
I think we'd all like to know that. And so I'm just gonna,
Let me get out my crystal ball.
if this individual tonight is watching, I would say that because based on the limited information provided, that's a question that might need to be reserved for your dentist. So happy to answer those questions, but obviously.
Is it Ellen that asked that question? Did you do something to screw her up?
Yeah.
No.
I'm just kidding.
I think the person got so excited that they were going to get asked a question in front of such a large audience that they could ask a question in front of such a large audience that they forgot to put the procedure in there. So anyhow, we'll save that one for next time. But there was also.
Hey, let me throw something at that though. It's all about risk, and it's all about the risk that the patient comes in with, whether it be how the patient is functioning, whether the joint is healthy, whether their airway is healthy, what the skeletal pattern is, what the habits are, what the home care is like. There are so many risks for dental care, and for the teeth, even without dental care, that really go back to the patient's risk, that a conversation needs to be had between patient and dentist where the patient says, what are my risks? What are the risks I'm presenting with, and what are you doing to mitigate those risks? That's where that conversation needs to go, because no answer can ever be given to how long should this procedure last. There is no answer to that under any circumstances without understanding an individual patient's risk.
I would agree. And I appreciate that. There were several questions from all over regarding dental technology, modern care, radiology, technology in dental offices. So I think maybe our next consumer facing could focus on maybe radiology, difference in 2D, 3D, various technologies that we should look for in dental offices, and so on and so forth. Wellness scans, the whole 9 yards. There's a lot that
Can we do lasers?
We can talk about lasers.
Lasers.
Yeah, but I mean, this was a very spirited conversation. And so, Jeff, why don't you close us out, since we got through some things tonight here?
Wow, you just really threw me under the bus. I just came here to be like a listener at the end, because I finished my webinar. I got my little bit.
Thanks for coming tonight, folks. Really appreciate it.
What's that? What just happened?
Thanks again for coming tonight, folks. It was a wonderful show. We really enjoyed having you here.
I'm learning to explain more.
You just kicked off my Alexa. Alexa,
Sorry.
Alexa, not right now.
Yeah, we just have so much fun with each other. Sorry, buddy.
Not
we
today.
I was supposed to just be a viewer tonight. So
no, we were really glad to
You're
see
never
your
just
face.
a viewer to us, Jeff.
Yeah.
Never just a viewer.
Yeah. And y'all can't make fun of me anymore for not being smart, because I've taught y'all both something tonight.
That's true.
There you go.
Can't remind you
Wait.
enough. We're back next week at 8 p.m. Eastern time, so Hefe can get his beauty sleep. We'll see you then. Good night.
Good night, everyone.
Good night, everybody. Have a wonderful evening. Thanks for being here.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.